Buenos dias, direto de Barcelona, na Espanha, indo para o Edentulism 2025 aqui no World Trade Center. E vamos ter a honra de entrevistar o professor Tomas Albrektsson, simplesmente o maior nome vivo da osteointegração mundial, que deu uma conferência espetacular ontem falando sobre sistema imune e osteointegração, e vai conceder esse bate-papo comigo, com o Peter Ilg e com o André Sakima. Aguarde que teremos surpresas. Ele está lançando esse ano o livro comemorativo dos 60 anos da osteointegração. É uma honra, né? Valeu, até lá. Olá pessoal, tudo bem? Mais uma vez nós estamos aqui com um grande amigo, o professor Tomas Albrektsson. E eu, o Dr. André Sakima e o Dr. Peter Ilg vão ter um bate-papo com ele a respeito da sua carreira, né, da sua vida. Ele é um grande amigo, talvez a pessoa mais importante da osteointegração ainda vivo, e vai lançar o seu livro de comemoração dos 60 anos da osteointegração. Então a gente vai bater um papo com ele. Hello, Thomas.
Hello, Luis. How are you?
Thomas, I want you to talk about your new publication, the book celebrating the 60th anniversary of the osteointegration.
Indeed. This book, you see, the 23rd of September, this year in 2025, it will be 60 years ago precisely when Brennemark treated his very first patient, who agreed that he used his name, Mr. Larsson, right? Totally Edentulism fellow, who had his implants for more than 40 years. And that's what we're going to celebrate. So we have chapters on history, we have chapters on even on zygoma implants, of course, in this case written by Dr. Davor, whom you know.
Okay.
Yes, and also about some novel implants, such as the N1 implant system, which I think is very interesting indeed. I'm not sure whether you are familiar with it, but the N1 implant is a combination of a rounded body where you screw it home, but a tri-oval design in the top part. And the drilling sequence is done using something called osteoshaper without cooling. Okay. And it has been demonstrated that this preserves the bone tissue. You don't get the typical necrotic border zone that you have with any other performance that you do with intraorally, with implants.
That's great, Thomas.
So that's a very interesting new type of implant. It's been around 3, 4, 5 years, something like that.
Another question to you. I remember when you was in Bahia in 2019.
Right.
You talk a lot about the same theme that you discuss here in the ZAGA conference.
Right.
About the autoimmune system.
Right.
And it was very interesting for us to see you talk about a new, not a concept, a new way how to see the seal of the osteointegration and protecting our body.
We have changed our opinion drastically ourselves, right? In the past we thought that osseointegration depended on bioinertness of titanium. Now we understand and realize and can even measure it, that titanium evokes the immune system. And what the immune system does is to produce bone around the implant to protect nearby tissues. This is 180 degrees from what we believed in the past. The immune system has another excellent quality, I must say, although we fear it a bit, that is that it can cause organize aseptic bone loss. Most of the bone loss we see is not at all a disease. That is a misunderstanding by our friends in the perio circles. It is aseptic bone loss, controlled by the immune system, that controls the balance between the osteoblast and the osteoclast. And if the osteoblast is given more attention, then we see bone resorption, or vice versa if the osteoblast is given more attention by the immune system.
Oh, that's okay. Let's see about Peter, what to have to ask to you. Peter.
Well, first of all, it's an honor to be speaking to you today. Sometimes we see a lot of debris around the implants and pus coming out. Obviously, you have sometimes contamination of the surface of all different kind of implant systems. Sometimes if you get it cleaned out, it works fine. Otherwise, it progresses. We've seen it in Brazil many times, mostly with low quality implants. What would be the advice on those cases?
Well, firstly, we have to identify what pus is. And pus is a fluid product of inflammation, not necessarily having anything to do with infection. Could have to do with infection, but it's a fluid product of inflammation by definition, right? And we are not saying that implant disease is not there. We think that when the aseptic bone loss is provoked by outer factors that combine to cause problems for the implants, then the immune system that prevents bacteria from actually attacking the implant more or less surrenders. And then we have a free room for bacteria. So in the failing implant, hopefully those are not that common, but in the failing implant we always see peri-implantitis proper, or nearly always. I mean, I can't say that in every case, but I believe in almost every failing case there is peri-implantitis proper. What is new is that the bone loss, if we lose a thread or two of bone, need not at all be any peri-implantitis, and the disease has been overestimated a lot. People have thought in the old days it varied somewhere between 6 and up to 50% at the implant level. That is not correct at all. It does exist. 1 to 2% of our implants, they fail in this manner, right? And of course, if you're, as you indicated, if you use poorly controlled implant, and not in your case, of course, but if you are a poorly trained clinician, then the figures can rise. They can more problems, of course, right? So we aren't guaranteed these fine figures, but with clinicians who know their way and work with controlled implant systems, that's what they see. About 1%, maybe up to 2% of problems in form of infection.
Yeah,
that comes later.
Great.
Professor Albrektsson, thank you for your time with us. It's such an honor to be here talking to you. Remember when in the early 2000s, Dr. Maria Lúcia Rubo Rezende, who was my mentor at Centrinho Hospital, she did her PhD, I think, with you in Sweden, if I'm not wrong. At that time, she was researching about the surface, how to clean it out, to try to do a reconstructive techniques to gain bone again, and for that bone to osseointegrate again. My question is, what is the status of these studies? What's the, state of the art of this situation?
Yeah, I remember the thesis project, but not in great detail. It was some time ago, so I'm sure I can't answer that. But if you look at the situation of re-osseointegration as such, it has been difficult to prove because we can't use radiography. Radiography has too poor resolution for us to see a proper re-osseointegration. But we have now seen it in other cases, in patients too. And that is when implants lose bone, inevitably you will have plaque on them, right? And that plaque you can never remove mechanically, but you can remove it chemically. And there is a technique available for chemical removal, and then you can have a perfectly clean surface. And it's been demonstrated that using this cleaning procedure, the chemical one, then you can actually have re-osseointegration clinically too. It could have been demonstrated also in that thesis, but I don't remember precisely the details of it. I'm sorry.
No problem. The question actually is not about the details of the thesis, but what's the current status on the researchers in this area? If there's something new, or a new surface, new products to do the cleaning, or it's still at the same status as at that time?
I don't think you can clean an implant that has plaque and other problems on parts of its surface with mechanical instruments.
I see.
You can clean them relatively so, but you can't clean them 100%. So you won't, it's very difficult to regain osseointegration then and prove it to be there. In fact, when it was demonstrated in this study that I referred to after the chemical cleaning, it was the failed cases they could look at, right? And prove that they had some re-osseointegration in the failed cases, although they decided to stop the procedure there. 91% of their cases succeeded up to 4 years, despite that they had lost more than half of the implant length in bone.
I see.
So this was Dr. Schlee of Frankfurt University,
Oh, I see. So
who did these studies, right? And together with some co-workers, of course. He wasn't alone.
Interesting. Am I allowed to do another question? Last one. This one is about the so-called saucerization on the platform level and the abutments, different types of abutments that were developed, and on from our knowledge, we think that new designs of implants are being developed in trying to avoid this kind of situation. In your view, is there any better type of abutment connection to prevent this ulcerization? As we saw in the lecture that this is not a bacterial issue, it's more of an inflammation issue, in the body trying to get the biological distances. And what's the current knowledge on this situation?
Well, as you indicated, this has been a case, not even the wildest periodontists of our university, and they are pretty wild, that would call that the start of peri-implantitis, but it's a local problem. And it's the saucerization in question, and it is smell, etc. And we have, by using platform switching, been able to demonstrate that this problem goes down. I would say that with very modern implants, such as the N1 implant, that has a triangular stem, it is probably, I haven't seen any cases of it so far, but whether there are any I don't know, but I haven't seen any cases of problems with that. That is a very stable connection with very little, and a great platform switching too. So inner solutions have in that sense proven to be better than hexed solutions, to give you one example. And hex solutions have some problems, right? They also lose bone a little bit more in the first year than inner solutions do, right? In the first year, as you know, not even periodontists believe that is peri-implantitis. That is a remodeling year, but still they lose more bone in the first year, and that bone is not coming back, generally speaking. So I think that we are seeing, what we are seeing now is a move away from hexed surfaces, gradual move away. It won't happen overnight. And we will see more and more inner solutions, right? They have been around for quite some time, but they've been refined a bit, and we have better results with them now, I would say.
Who is collaborating with you in this publication?
Oh, we have, I can't tell you how many authors there are. There are a great load of authors, right? People from this meeting, I did indicate Dr. Davor, who's written about zygoma implants, for instance.
Frank Renoir too?
Sorry?
Frank Renoir?
No, Frank Renoir is, in this case, was not in, he could have been, I'm sure, been able to write a wonderful chapter, but we had to have, in this case, I would like to invite him for many things, but in this case, we had others writing the clinical chapters. And we have some historic chapters. We even talk about orthopedic implants that we made with osseointegration, and of course with the extraoral implants. We have a chapter too, right? With the so-called bone-anchored hearing aids and the epistases used to repair faces. But the majority of chapters relate to dentistry, of course. And the N1 we have, that I talked about before, we have 3 or 4 chapters on the N1 implant only, because that's such a promising thing for the future. That really, I think, that principle is something that we will see a lot of in the future. That is, I would call it the most future implant we have today. Tomorrow there will be another implant that is more future, promising for the future perhaps, but this is by far the one that I think very much of today, the N1.
That's very nice. I have one more question. Today, 20 years that we are friends, that I
Indeed.
met you in the 40th anniversary of the integration. But what can you tell for the next generation, the future? What do you think about? You was there when the first implant was put, and there, what do you see in this conference that impacts you today?
Well, I think that the recommendation for the young people is the same as the one we had many years ago. It hasn't changed, right? Educate yourself, learn your tasks. Don't run and do the difficult things. When you start with implants, have them unloaded in the mandible for 3 months, and in the maxilla, if you even dare working in the maxilla when you are a beginner, for 6 months. Do not ever consider using non-documented implant systems. And if you do, when you are more experienced, you have to tell your patients that I'm using an undocumented implant system and I want your consent for using it in you. If you don't do that, you violate the oath you have sworn when you treat patients. We are seeing too many undocumented implants, and we have seen in the past one system after another going down the drain and disappearing. Admittedly, some of them have survived too, but it's very difficult to tell when you have in front of you an undocumented system which one is going to survive and which one is not, right? Because they are manufactured. Generally speaking, they are more dirty than other implants. There could be exceptions, that's right. They need not be more dirty, but since those who manufacture them don't want to spend the extra dollar to do research, etc., they don't want to spend the extra dollar to clean them. So when we have looked at some of them, they are very dirty. We don't know exactly what it means. They could have organic impurities. They could have all sorts of problems. There is a gentleman in Germany, a dentist, Dr. Dudek, who is running the Clean Implants organization, that I think is an important one to follow. We need clean implants, like we do with everything else we work with in patients.
Okay, Thomas. So we are waiting for the launch of the book.
All right.
And congratulations again. Thank you for your career.
Thank
you for your knowledge, your friendship.
And a pleasure seeing you again, Luis, and thank you very much, gentlemen, for your kindness. Thank you.
Para terminar, eu quero agradecer aqui a presença do Dr. Peter Ilg, do André Sakima, nossos amigos que partilharam conosco essa entrevista, talvez histórica, né? Muito importante para nós no Brasil. Valeu!
Pois é, acabou de terminar o Edentulismo 2025 aqui em Barcelona. Estou aqui dando uma caminhadinha, voltando para o hotel. Cheio de conhecimento, cheio de amizades novas, interação, aprendizado, equipamento, muita tecnologia, tudo para tratar o edentulismo total superior. Foi muito bom ter vindo aqui, muito legal mesmo. Depois eu vou contar um pouco mais dessa história, mas avaliando aqui, foi uma experiência. Não é só legal, é porque eu ainda me encanto pelo fato de querer aprender mais, sabe, de aprender com outros colegas, com a experiência de outros colegas. É uma coisa que ainda está muito viva dentro de mim. E que bom, né, que a gente continua assim. A vida fica mais legal, mais divertida. Aprender sempre é bom. Valeu! Barcelona 2025.